excuse me, people join us. Feel free to turn your cameras on. You don't have to, but feel free to. And welcome to this is the October edition of MaineHealth's Public Health Grand Rounds, except that it's September 30th. So we're doing a Public Health Grand Rounds a week apart because we've had to accommodate some speaker schedules. So I will start the introductions, at least I know as people are still coming on, but really thrilled to welcome Corby to Kummer. Kummer or Kummer? I've heard it both ways.
Depends on which side of the family I say Kummer.
The Corby Kummer. I should know, but I've actually heard your name pronounced either way, so I'm thinking, okay.
Me too.
Corby Kummer. So yeah. To our MaineHealth Public Health Grand Rounds. Thank you so much for joining us, Corby. And he is a true titan in the world of food and food policy. Corby's career is actually a testament to the power, I think, of thoughtful writing to not only inform, but also shape how we think about what's on our plates and in our communities regarding food. Corby currently serves as the executive director of Food and Society at the Aspen Institute, a role he's had for over a decade. I would also say he's a tremendous speaker, and if you Google the Aspen Institute and Corby Kummer, they've recorded his presentations from the last several years at the late June Aspen Institute, and they're fabulous presentations. So he's been at the Aspen Institute, as I mentioned, for over a decade. He gathers chefs, policymakers, public health leaders, farmers, and others to find practical solutions to really the systemic challenges that our food systems are facing, with basically the ultimate goal of helping everyone to eat better and more healthfully. You may know Corby also from his long and distinguished career at The Atlantic, where he's been a senior editor since the 1980s. His influential writing, which often focused on food, Italian cooking, sustainable farming, has earned him the title of the Dean among Food Writers in America from the San Francisco Examiner. And the legendary Julia Child herself, or some of us know her as Julia Grownup, once also praised his work, saying, "He really does his homework. As a reporter and a writer, he takes his work very seriously." So in recognition of his exceptional journalism, Corby has been honored with 6 James Beard Journalism Awards throughout his career. Beyond his magazine work, he's also a celebrated author of books like The Joy of Coffee and The Pleasures of Slow Food. And for those of you from the Center for Health Improvement who are participating live, we are going to be giving out 10 books of The Pleasures of Slow Food. Libby will run her magic of doing a random selection of 10 people who are attending live to give those books to. But Corby's influence extends far beyond the page. He is a senior lecturer at the Tufts Friedman School of Nutrition Science, where he helps educate the next generation of food leaders. And he's also a familiar voice on the airwaves, serving as a weekly food and food policy commentator on WGBH's Boston Public Radio. So today, we're very thrilled to have Corby joining us, bringing his decades of expertise and insight to our conversation. His work at the Aspen Institute is particularly focused on initiatives that address food justice, improving access to nutritious food, and fostering sustainable practices from the farm to the table. So please join me giving a warm welcome to Corby Kummer. And thank you so much. Welcome to Maine and MaineHealth, even though you're attending virtually. But it looks like you're in a place with as good a weather as we've got. It's also sunny and warm here. So thank you so much. And
thank
please
you, Dora.
And I'm so sorry, and please feel free to put any questions you might have in the chat. And we will also be at the opening up for questions as time goes along. And thank you, Ellen, for putting a link to his recording from the Aspen Institute from this last summer. So thank you, Corby. I'll send the baton over to you.
Thank you. I think we all want Dora introducing us at every possible talk, and you'll soon find she sold you a bill of goods. But I'm still very honored to be here and delighted to talk about the work that my program at Aspen Institute has been doing on food as medicine. I'll be even more delighted to hear from a lot of you on what you've been doing regarding nutrition education and nutrition interventions, because there's so much alive issue right now in food. And I'll talk a lot about the uncertainty about funding for these programs and be asking you your experience. But what I'll start with, and I did not turn my camera off, so I'm not sure. There it is. Let's hope it stays on. Um, what I'll start with is some about the history of food as medicine, and how I got involved, but also it's interesting, the history of food as medicine, and kind of unexpected. So I myself am not a medical person. I'm not a diet doctor. I don't even play one on TV, although I play a judge on Beat Bobby Flay. So many of the rules of the food as medicine programs I'll talk about apply to healthful diets in general. And I'm glad to talk about ultra processed foods, seed oils, other foods that are in the news because of the new Secretary of Health and Make America Healthy Again campaign, which has put food as medicine front and center. It hasn't funded it, but it's put it front and center in a lot of public calls. I'm on daily calls about food as medicine, and lots of concerned talk about cuts to nutrition benefits that have long been the backbone of public health programs. There's a quiet but persistent thread of hope. Maybe the government will finally take chronic diet-related diseases and prevention seriously, which are the chief goals of food as medicine. So the opening of the vision and goals section of the Congressional Make America Healthy platform started food as medicine, promote access to nutritious, affordable food, and encourage education on ingredient impacts, processed foods, and healthy eating habits to facilitate healthy outcomes. So you see how many from all political stripes, that was written by very solidly red state coalition about the Make America Healthy platform again. So we've all been surprised and gratified by that kind of language. What we're all hoping to see is funding that backs it up. But the language does exist, and it was there. Um, as Dora said, I didn't start out as a food policy person. I wrote a book about the slow food movement, which united food justice and environmental concerns to eating well and gourmet food in a way that was novel, important, and later became popularized by various food writers, including Michael Pollan, who took enormous numbers of ideas from the slow food movement, as did Alice Waters in California. They were both hugely influenced by the formation of slow food, which really married social justice and environment concerns. And and food access to an extent, I would say the U.S. has added food access as part of that. And I became very interested in what the food industry could do to help increase affordability and access to a more healthful food. In the early days of the Obama administration and Michelle Obama's Let's Move campaign, the government was working to reformulate industrial food, or the administration was, the executive branch. Reformulation is a crucial effort. It's invisible to many consumers by design. Healthier food is seldom a winning business proposition unless you're in the high-priced province of Whole Foods. So stealth health, as it's called, measures like eliminating trans fats, which became national law, increasing whole grains and fiber, which were part of the Healthy Hunger-Free Kids Act passed under the Obama administration. Lowering added sugar and sodium became what I most wanted to highlight. And I learned that policy, regulation, and federal spending were the best ways to make food healthier. Now, an update on that. It's still, even in the new Make America Healthy policy report and action plan that came out just 2 or 3 weeks ago, it's all voluntary regulations. There's no new regulations. There's no new requirements. which especially around lowered sodium is probably the only way to lower sodium, which many of my public health mentors consider the biggest and easiest win that industry can achieve. Um, by voluntary self-regulation, everybody has to volunteer. It's the tragedy of the commons problem. If one brand, Progresso was the notorious example, when Campbell's and others under the early Obama administration made lots of noise about reducing sodium in soups, which along with the surprising packaged bread are the highest contributors to sodium in packaged food. Um, it worked fine for a while, and then Progresso didn't lower in lockstep with the other manufacturers. And if one company is a renegade and doesn't, the sales will all go to that company. So they all went to Progresso. So regulation is hugely important, as is funding. Um, every farm and federal act regulating school food in all of the potato industry, which is dear to Maine. And my grandfather sold Prince Edward Island and Aroostook County potatoes. It was his business in northern Connecticut. So he came north to Aroostook every fall and brought back truckloads of potatoes and brought them back to New York also. Um, but in any case, potato industry has always carved out an exception for unlimited fried potatoes at breakfast in schools, ketchup as a vegetable, but still, it's always worth reminding that school food is the country's most important nutrition program and powerful way of reducing hunger. It's a crucial fact to keep in mind, especially right now when so much nutrition aid, subsidies, SNAP benefits, they're all on the table and a lot are being cut or threatened to be cut. School food is hugely important, and I think what remains of SNAP and school food is going to become more and more a focus of attention and gratitude that it's still there. So I'm enormously focused on school food. So food as medicine is a controversial term and it has a squishy definition. In fact, the program I founded on food at the Aspen Institute called Food and Society held a meeting recently in Tucson, the Andrew Weil Center for Integrative Medicine, to try to sharpen what have become increasingly blurry definitions. More kinds of health providers, companies, and community-based organizations, like I hope the ones many of you are working with and can talk about later on this call, have entered the field or tried to. But what are they talking about and hope to accomplish when they say that they're going into food as medicine? I think I can start sharing some of my slides. So I'll see if my window will cooperate and we'll start. Um, so that's the logo of Food as Medicine and also the report, which I'll refer to later, that's a very easily downloadable online of all of the peer-reviewed research into food as medicine interventions, medically tailored meals, medically tailored groceries. This was from one of our recent meetings on defining food as medicine. In fact, this is the very meeting in Tucson because you see the tall guy with glasses at the back who's the head of the Andrew Weil Center for Integrative Medicine, just national practitioners on food as medicine and how it should be defined. So here's how we define it. It's got a nexus to the healthcare system. And often patients are referred by the healthcare system. So this is our working definition. And then at the bottom is a recent administration definition of it, the nutrition affordable food. When I say recent, I think it was right before the election because Health and Human Services was working very hard to zero in on many aspects of food as medicine and how to measure metrics and how to measure improvements for the all-important return on investment argument. Um, here it is, healthy food. And so the notion that food influences health is ancient. Hippocrates advised physicians to let food be thy medicine. 400 before Common Era, delightful short book called How to Eat, an Ancient Guide for Healthy Living is full of good advice on like how to wake up. You rub olive oil carefully all over your body, slowly, with fresh cold water on the face, and what to eat to promote health. This is 400 BC. The ties to seasons and the earth in the ancient world are profound and explicit. But the modern food as medicine movement in the US has much more recent roots, and it comes from both motivations, practical and concerned with the nation's defense and alleviating poverty. In the early 20th century, we saw the discovery of vitamins, the relationship between nutritional deficiencies and diseases like pellagra and scurvy. The first large-scale nutrition program was for potential recruits because they were nutritionally deficient. This was as the country was gearing up for the Second World War in the late 30s. It was a way of ensuring a national reservoir population of healthy young people, young mostly men who were fit to serve. And I can't say enough, that's when school lunch started. It's still the most important way to let 30 million children succeed at school and keep families out of poverty. So that's in the late 30s. It gets on going in the 1940s. And then the 1969 White House Conference on Food, Nutrition, and Health was a pivotal moment for health. And we're going to come to modern food as medicine. It was set in motion by Jean Mayer, charismatic World War II hero who founded the school where I teach and will be teaching in an hour, the Tufts Friedman School of Nutrition, Science, and Food Policy. And it signaled the first time that the federal government concentrated on a problem that seemed unimaginable in the world's richest nation coming out of the Second World War, which was hunger. That conference led to the expansion of the food stamp program. It had existed, but it became much broader after the 1969 conference called SNAP Now. And the establishment of the WIC program, Women, Infants, and Children, it's all a result of that conference, and it began in 1972 under an entirely Republican administration. Um, and it now serves about 6.2 million participants monthly. It reduces anemia among low-income pregnant women by 34% since its inception. WIC is the original and still the most important food as medicine program because unlike SNAP, it has strict nutritional requirements that since its inception have hewed to principles of healthy diets. These principles have changed remarkably little in 60 years. High in fresh fruits and vegetables, whole grains, and dairy and lean proteins. And the first thing you probably think of when I mention those foods is money, because they're all expensive. And it's becoming increasingly hard to follow that diet. The modern food as medicine movement, as we know it, truly began in the late 1980s and early 90s with community-based food assisted programs for HIV and AIDS patients. So in 1985, God's Love We Deliver was founded in New York City, Project Open Hand in San Francisco, and community servings. By night, which I say here because it's actually less than a mile from where I'm speaking to you in Jamaica Plain, Boston, its current headquarters. I was a founding board member of it. It's what brought me together with my spouse because we both were founding members to try to get it funded and try to get it operational. And today, the Food is Medicine Coalition, which is a group of nonprofit meals programs on health and health serving medically tailored meals, serves tens of thousands of client meals at agencies across the country. And they're usually designed for clients with several interrelated illnesses. So comorbidities is a tremendously important part of what the Food is Medicine Coalition would define as medically tailored meals and understanding the intersection of Venn diagrams of what comorbidities require is a very important part of food as medicine, and it's not that understood by for-profit companies that are trying to get into medically tailored meals now. So the research, that's what these pictographs on the right show. At the beginning, Seth Berkowitz, I'll be coming back to Seth Berkowitz. He was at the Children's Hospital in Boston. He's now at North Carolina at UNC. He was the first to study the effect of food as medicine and medically tailored meals in adolescents. And there were path-breaking studies that he did in partnership with community servings that began in 2004. Berkowitz and Harvard researchers were documenting that improvements of diet could reduce the risk of cardiac or cardiovascular disease by up to 30%. That was the result. No pharmaceutical company could claim significant reductions in ED and hospital readmissions. That was short-term investment on return on investment that large-scale payers like Medicaid wanted to see. So several years after Berkowitz began publishing on food as medicine in 2004, community servings meals programs demonstrated a 16% reduction in healthcare costs and a 50% reduction in hospitalizations among patients with diabetes. Um, it's studies like these and the promises of presenting that kind of dramatic reduction in costs to healthcare payers that led to the name food as medicine. And I should say, if any of you have spent any time in the fields of food as medicine, you'll see it referred to as both food is medicine and food as medicine. It's still a very controversial name. Um, Food as medicine slightly removes the implication that food is a pill or a drug or medication. Pharmaceutical companies hate that. They don't think, they make medicines, they don't make food. Food is a medicine. And many nutrition researchers don't like it either because food's a daily necessity. It's a source of enormous pleasure. The idea that it can or should be medicalized, chalked on a blackboard to certain researchers and practitioners. The food as medicine is here to stay. It's what I use. It's what the field uses. Go ahead, call it food as medicine. That's what I think. So even with this encouraging base, the research base remains thinner than payers want to see. And the lack of replicable short-term returns on investment impedes the growth of the field. My program at Aspen was lucky enough to be funded for a 3-year project, gathering in one place all of the peer-reviewed research to date in the interventions that fall under the category of food as medicine, principally medically tailored meals, medically tailored groceries, which are boxes delivered, they're much more economical, and produce prescriptions, which are the most economical but the most mixed in long-term findings. Also, WIC, school lunch, and meals for older adults. Those are federally funded nutrition interventions, and so we looked at all the peer-reviewed research into that. Our first draft was released in the spring of 2022. Last spring in 2024, we have released an update including much of the evidence of the enhanced and extended feeding programs, particularly school lunch for families and summer feeding programs, these great pandemic extensions that have sadly sunsetted and may not ever come back. Brave states like Massachusetts continue that expansion of school lunch. But in the face of current job losses and federal budget cuts, hunger is going to increase. And the USDA funds that were keeping small farmers alive in the Farm to School program and current threats to SNAP benefits will show first and most lastingly in young families and the next generation of students. So it's a big source of concern. Here's just, you probably all have statewide food insecurity statistics that you can claim. These are recent federal statistics. I think that a lot of you saw that just last week, the USDA announced that after this year, it will no longer do the annual food insecurity survey. They said it was redundant. It's not redundant with anything national or anything unified. It's absolutely crucial. And of course, the whole goal is if you can't measure it, you can't complain about it, you can't understand the magnitude of the problem, and you can't address it. So it's very alarming, the end of the National Food Insecurity Survey. They've also said that food insecurity rates have remained stable for the last few years. It's not true. They've gone up. They've fluctuated. It's crucial to see this. So we're going to have, much less an idea of what these national results are. It's going to have to be piecemeal in the future, like so much of food and nutrition interventions in the next few years, piecemeal, state by state, and maybe state coalitions like we're seeing around vaccines. So where do we stand today? First of all, here is where this is the cover of our revised Food as Medicine Research Action Plan, which I'm glad to say is still foundational to anybody interested in what research results are. It hasn't come down from the NIH site. They put it up as one of their main tools. They haven't taken it down yet. Maybe they haven't noticed. Don't tell them. But we're very glad that it's still HHS and NIH still list this guide. It's easy to find under aspenfood.org. So we've got a patchwork of interventions that happen. So here are some of the great statistics about medically tailored meals. ED down 50%, 70% hospital readmission, 16%. Medically tailored meals are the most expensive interventions, but they also have the best results. Produce prescriptions. It's wonderful for increasing consumption of fresh food. And I think what Dora and what Dora was telling me is how many of you are very active in nutrition education, in helping people understand how to use fresh produce, which is part and parcel of produce prescriptions. It's too often neglected. SNAP Ed federally has been defunded, but HRSA, there are several cut-throughs and back doors to nutrition education I think some of you in Maine are finding to be able to continue nutrition education, because it's just crucial whenever we talk about produce prescriptions. So education is so important. So medically tailored meals, medically tailored groceries, produce prescriptions, and probably a lot of you help with Double Value and Bounty Bucks. And I hope you're familiar with Wholesome Wave, which was founded right here in Jamaica Plain by Gus Schumacher, who later became the Deputy Secretary of Agriculture under Clinton. And it's now called GusNIP, which is the Gus Schumacher Nutrition Incentive Program. It's wonderful that it became the kind of entitlement covered benefit that there's just not enough of. So here's some of the very good food as medicine. And I'm glad about our including the depression statistics, because mental health is so important in thinking about nutrition interventions. And I gather that Maine has applied for an 1115 Medicaid waiver around substance use. And depression and mental health should never be neglected when it comes to nutrition interventions and the values of food as medicine. And of course, health disparities has been kind of where it's at for a lot of food as medicine activists. And now we're not allowed to talk about it much. And then the main costs about diabetes and what food as medicine could do. So I'll skip over some of the statistics about what it could do, because we're so worried about what funding is going to be available right now and in the near future. Because as you're all very aware, healthcare system is mired in a fee-for-service model. Medicare will cover dialysis for kidney failure, about 90,000 per patient a year, but not medically tailored meals that might have prevented that kidney failure at a cost of 4,000 per year, unless Medicaid waiver. The big waiver states, and I'll be glad to talk about this more, have been Massachusetts, North Carolina, and California. They've been the longest standing, and so the best longitudinal research is available from those states. And a lot of that data are available in our Food as Medicine Research Action Plan. The author of the revision is in charge of Kurt Hager at UMass Worcester. Formerly at Tufts, is in charge of the largest statewide longitudinal study of benefits of food as medicine. And I'm sure many of you are familiar with natural experiments, looking at states around Massachusetts that didn't have the same funding. What happened to their food insecurity rates, their diabetes rates, at the same time that the 1115 waiver in Massachusetts was in effect? So funding is still the barrier, and 1115 waivers and pilot programs. Our longstanding goal in food as medicine is to see pilot programs and 1115 waivers became part of covered benefits under combined Medicare and Medicaid services, and not just pilot programs and waivers. But now the waivers themselves are very threatened, and the future is uncertain. And I wonder if any of you, and let's talk about uh, state by state Medicaid waivers. There was a fabulous article in yesterday's New York Times about North Carolina deciding in the spring that it would prophylactically end its national, fantastically effective 1115 waiver that allowed housing, a lot of food, um, and some transportation assistance that was especially important. It was, I think it's one of the first from 2018 or 19 pre-pandemic. But after the hurricane in Asheville last year, we are all looking at the 1 year anniversary. It's been terrifically effective for helping families get back on their feet for both housing and nutrition. The state legislature halted it, and I think June 1, it ended with a possible renewal by today, September 30th, which is the state's fiscal year, which is why the Times ran it yesterday. We'll see at the end of today whether North Carolina's state legislature decides to re-up it. They were worried that the state portion of Medicaid wouldn't be able to continue to fund the waiver. But when you look at the family by family, county by county benefits that that North Carolina waiver has had, including a 14 or now 16-year-old with hydrocephalus who was having constant seizures, inattention, and once he had fresh produce, his seizures reduced greatly, his attention to school, all of it hugely increased. It's gone right back down after the June 1st deadline, and his mother is enormously um, worried. And it's these person by person stories that all of you are familiar with. It's stories that help make the case. Um, Food is medicine, diabetes. We had a meeting in Tulsa, which is very active in culinary medicine. The University of Oklahoma at Tulsa has been doing food as medicine programs for years, and talked about a lot of what would be necessary to get more funding to reduce diabetes. And as it's person and family by family, it's community-based interventions and organizations that can be the most innovative ways clinicians. Dora was telling me about food pantries in Maine, smaller organizations that have been really innovative in education and nutrition education and consultations, which are so important. And what my program at Aspen is now working on is a community action plan. What does it mean for a community-based organization to get into food as medicine? How can it help? And so we're trying to sharpen definitions. Here are some of the findings from a meeting we had in Tucson that I showed you at the very beginning of it, and how many community-based stakeholders need to come together to increase progress. So here's the overarching message, tremendous momentum, but it requires more integration, more innovation, which is going to be required as funding goes down. And I think I should end there because you'll all have enormously important and terrific contributions of your own to talk about and answer any questions I'm able to, but I'd love your participation. And thank you all for listening.
Oh my goodness, that was fantastic, Corby. Thank you. And I was particularly interested in, I remember you and I talking a couple of weeks ago about the roots in the HIV/AIDS movement. I don't know if you can just, and we've got a lot of questions in the chat too, we'll get to, but just wonder if you could just expand on that. So it was people with AIDS who were then recognizing that the food was also, healthy food was part of the healing and treatment, or?
You know, it has a sort of, there are several origin stories of these Food and Medicine Coalition members. In New York, it was a woman who was like dumpster diving to bring food to AIDS patients. What was crucial was they were shunned. No one would come to see them. And so often the only contact, and that's a very fundamental part of Meals on Wheels program, it's the only human contact people have who are unable to get out. In Boston, it was a group of, I was involved with the first fundraiser for HIV, the Corporate America Bank of Boston. It was the first time they would allow their name to be anywhere near HIV and AIDS, but they came together for a fantastic fundraiser, and Julia Child was the honorary chair, and I drove her to it.
Oh my
Joan Rivers
goodness.
entertained. So this was, a fantastic community effort, but we wanted a more lasting way of helping day by day. And many of the top restaurateurs in Boston came together and said, we're going to bring gourmet meals to people who are dying. Isn't it going to be fantastic? And they had no idea that's the last thing that people who are dying could actually eat or digest or use. And so they had to abandon that dream pretty soon and understand that there are enormously specific nutritional needs for people at various stages of critical illness that would actually be of the most benefit to them and help keep them alive longer. Then drug cocktails became widely applicable. Right in the years before that and during the introduction of drug cocktails, the Ryan White Care Act was the first hugely important federally funded use of money to help critically ill people. It's the first. And it's the most important association with delivering people food around critical illness. So the HIV programs took these insights and began increasing them to end-stage renal disease, severe type 2 diabetes, not around HIV. And they
Wow.
understood that this was the way forward because drug cocktails were going to radically decrease funding, or even, thank goodness, the need to feed HIV patients. And so these programs all branched out into other critical illnesses, took leaves from hospital nutrition departments on how to help people with various forms of cancer, especially lung. Um, and breast. And my colleague Fang Fang Zhang at Tufts has done a tremendous amount about breast cancer, and I don't know why my camera is going out. Let's bring it back. Um, and so different end stage diseases resulting that could be improved by nutrition became part of the food as medicine movement. I'm still talking about medically tailored meals, but they're the most expensive. They're the hardest to administer on a broad scale basis. Medically tailored groceries have become very popular, really starting in the pandemic when it was much harder to deliver food to people, supply chain problems. It was also the rise of Blue Apron and various meals boxes. And that became a very persuasive way. And when you read yesterday's very moving piece, and I'm going to probably change camera feeds if I can, about the results of the North Carolina interventions, you see how it's mostly medically tailored groceries and food boxes that have been tried. Do you see me now?
Yeah.
Are you able to see it?
No.
Oh,
It's
okay.
been
So we'll go
back.
back to Cyberlink and try that. This is supposed to be the much better program, and this should be bringing me back. Um, okay, I'm going to keep trying with Cyberlink. But in any case, medically tailored boxes have been and groceries have been very important and helpful to helping North Carolina and various funded programs. I might be out for a while, but let's see if we can bring me back. So,
And
that's
we
all
had some
been a part of.
questions too. There you come. You're coming back.
Yeah, we have a
Great.
lot of questions waiting. So I was going to ask Emily Walters if you want to just, you've got a couple questions in here, including insights for the state level food as medicine centers of excellence that the federal government is pursuing. And Emily, do you want to just also, just as you lead our food as medicine efforts here, do you want to just give a brief overview of some of the projects that we're doing?
Yes, thank you, Dora. I really appreciate it. And Corby, thank you so much. This has been an excellent talk. And yes, my partner in crime, who's really the leader of our Food is Medicine work, Emily Kane, she and I have been blowing up the chat with some questions, but I just have to start by acknowledging that so many of the resources that have come out from the Aspen Institute have been absolutely instrumental to our team as we've been building our program here at MaineHealth. We've modeled a lot our logic model and our annual objectives around the tools and the resources that you are putting out. So thank you so much. And
I
it's just
couldn't be
it's
more
been
thrilled to hear it. So would our
oh
fund to the Walmart Foundation. I'll tell them.
well, pass it along. Thank you so much. So my initial question was regarding the Food is Medicine Centers of Excellence that we originally started to hear about through, I think it's through the NIH. And as we were building our MaineHealth infrastructure and team here, we really modeled it after the Centers of Excellence that we were sort of anticipating. There may be some funding opportunities to build centers of excellence at the state level. And I'm just curious if you have any insight for like where, if you've heard anything about where it is in the process of developing these centers of excellence or.
It's all in abeyance. We were really fortunate that, but I should say that the Nick Jury at NIH, who was instrumental in bringing together lots of the departments within HHS, it has not left. So he's still
Okay.
there. But the team of people at HHS who were working on the centers of excellence, which had as part of its charge, what metrics do we measure to show improvement across the 17 agencies in HHS? And I was on, like, we were having two endless meetings a week. I was on like every metrics committee around how do you define community health? What does that mean? And then what about food systems health? Are you worrying about land around there and farmers in your area? There were all sorts of fascinating questions that were going to be part of those centers of excellence metrics. That team, a woman named Rachel Fisher, she's still at HHS, but she's essentially being sidelined because the administration has said all work has to come from the executive branch. HHS can't continue any of it. Um, NIH in Nick Jury and Andy, oh gosh, this enormously nice pediatrician who always wears bow ties because kids contaminate long ties. Bremer, Andy Bremer. They're still there. And they've posed for lots of pictures with RFK Jr. So in essence, there's still verbal commitment to these, but no
Okay.
funding that we've seen.
Okay. Well, we're well poised should the funding opportunity come available. But thank you
Glad to
for
hear
that
that.
insight. Yeah, and I'd love to invite M. Kane. I know you put in the chat a comment and a question that we had around Maine's 1115 waiver. And Emily, I'd love to invite you to pose that question to Corby.
Yeah, thanks, Em, and another thank you, Corby. Really inspirational. And yes, we've looked towards the Aspen Institute for pretty much all that we do. So yeah, you feel free to send that along. So we actually, MaineHealth facilitates a statewide food as medicine work group, and we've been excited to have MaineCare, our Medicaid office, at the table. And so when that 1115 renewal came about, we were able to advocate and have them, encourage them to include in the health related social needs section some language around food as medicine, sort of standard. We worked with Chilpy to kind of design it, and we were excited that the state pretty much accepted what we wrote. It's quite broad in language, but right now, so approved, went off to CMS, public comment period ended. We're just sort of wondering, and if you have any insight as to like, we're hearing a lot more about budget neutrality being sort of encouraged, required, I guess. And so do you have any insight I think there's maybe 3 states that have waivers that are pending currently with CMS. Do you have any thoughts on kind of where that might go?
The short answer is no, but. And we're about to have a meeting about the payment landscape in Boston in the middle of November. And what everybody on Earth wants to know about is what's the status of 1115s, current ones and the pending requests. And um, so far, they haven't been refused, and they haven't been clawed back, and they haven't been touched. So that leads to hope. But then I spoke to, and this is third hand, a woman who gave me the name of somebody in the White House who apparently has it's a man, sights on eliminating all 1115s, and her advice was don't believe because they've been silent on it that they're not thinking about it. They just haven't gotten to it yet. So that's like cue horror movie music. That's exactly what we don't want to hear. Um, on the other hand, Dr. Oz gave a presentation at CMS a month and a half ago in which he talked about the importance of food and was very optimistic or giving verbal reassurances about how important nutrition was to thinking of health and the broader picture of health. And people, including my spouse, frankly, came away from that thinking, oh, they're actually going to take this seriously. So it's unknown. I don't have any insight into it. My bets are always that the White House will try to stop stuff because that's what they do. But there's still voices within CMS who are saying nutrition counts. That's the best I can do.
A lot of TBD. We don't really know. They haven't approved any new 1115 waivers, correct, in the last 9 months?
Well, not the 9 months. So in January, New York State had one since before the pandemic, a waiver including food. New York City's only started in January, and that might have been under the new administration, which didn't pull it back. They didn't start releasing any contract money until the end of February, beginning of March. So a lot of New York City agencies that had been completely planning on their revenue model based on this as of January had to wait and wait, but it started. So they have a whole bunch of social care networks. And by the way, one of at least the main findings we're having for our community action plan is that a middle group that helps with billings and HIPAA compliance is crucial for implementing 1115 waivers or any kind of healthcare payer that starts covering it. Healthcare payers will often say, I won't deal with CBOs. I believe in them with all my heart, but they're just too much trouble. Agency by agency can't deal with it, and they're going to screw up our whole HIPAA qualification. So in New York City, they're called social care networks that are the middlemen between the two. In other places, they're called community care hubs.
Yeah.
And there's several in California and North Carolina that I know about, but they are really crucial to trying to help very small FQHCs and even food banks bill to try to get CMS to reimburse some of it. But to get back to Emily Kane's question, I don't have insights. It's what I think about every day and try to pump my sources to tell me.
Thank you. And the community care hubs, I mean, I've been under the impression that they're mostly in states that have Medicaid managed care to be able to be a kind of a go-between a national managed care insurer organization and a lot of hospitals, FQHCs, and other providers. But we do have one here in Maine, but I think it's fairly small. But it's anyway. But Emily Walters also has a question about funding. Emily, do you want to just open up
Yeah.
your mic and answer? Ask that.
So one avenue we've pursued is the 1115 waiver, and so the other avenue that we've been working towards in partnering with our ACO here at MaineHealth is around working with some of our private payers, most specifically around patients with type 2 diabetes, and coupling it with a produce prescription. And at MaineHealth, we're using IQ Pay, which is really exciting as a platform to deliver these produce prescription opportunities. But just curious if you have any, or if you know of any other sort of innovative ways that you've been seeing private payers invest in food as medicine that we might want to consider pursuing here at MaineHealth or with our partners?
We've been seeing private payers head for the hills, and it is so depressing. So the most active and showing up at national organizations payer has been Kaiser in California,
Yeah.
and all of their providers really want to be involved with food as medicine. They've become more and more aware of it. They want to do it. But the insights of both, and Dora kindly watched an Aspen panel I led in which this became forcefully clear. The insights that North Carolina Blue Cross Blue Shield and Kaiser showed is that patient retention could be counted as a financial win. Whereas for other payers, the kind of A1C levels or reduction in healthcare costs, they take so long to show that they're not taken seriously as a return on investment. And so what we've seen is in innovation is shared medical appointments to try to get a nutrition consultation to be part of a reimbursed medical visit. And a woman named Jacqueline Albin in Houston, who was featured in one of my photos, said that she had 17 separate calls with CMS to be able to call the church basement a federally qualified health center where she could reimburse. So being able to meet patients where they live and where they will come, and then get that visit reimbursed and get a nutritionist reimbursed has been crucial. Something I don't know how you can get involved with or whether you have any kind of communication with the state VA, but the Veterans Administration is one of the best possible sources of nutrition consults that get reimbursed regularly. There's a small scale pilot going on with the VA for medically tailored meals and medically tailored groceries, and that took a long time in the making, and it's very exciting. The woman who administers it happens to be in my new cohort, my fourth cohort of something called the Food Leaders Fellowship that I run at the Aspen Institute. And she has like unlimited access to nutrition consults. So if you could get some of your patients to get into a family or knows their way into some member of their family who's within the VA, nutrition consults have been hugely promising because even when healthcare payers say, what do we want to fund food for? We're a healthcare payer. We don't pay for food, which is what she's going to encounter at the VA. If you help people understand what foods they should be eating for their specific illnesses and conditions, and you've been very innovative, I hear, in education and teaching people how to cook them. So getting a nutrition sort of prescription for what people should be eating, where they qualify for SNAP and WIC, which is like the best we're going to be able to do for a lot of patients, and produce prescriptions, but then the crucial education piece. All that are ways of piecing together funded interventions that can help people short of actual food, just having the food be in SNAP, WIC, and produce prescriptions.
Right. Well, thank you. And the other, I just wanted to mention, Emily Kane has mentioned in the chat too, that the MaineHealth Food as Medicine team is working with Fang Fang on 2 NIH food as medicine research proposals, and one being submitted tomorrow. So good luck. And there was a question up above that. Oh, Anne Rosario, do you want to unmute and ask your question, or you want to just read it? I don't know if she's.
Hi there. No, I can ask the question directly. How are you? First of all, Corby, thank you so much for your time and your information today. I have really been inspired and encouraged by listening to you. So thank you so much. So my question really relates to my day-to-day job. I'm actually a health coach. I work in the population health department, and I work with patients who have chronic kidney disease over at the nephrology department. So part of my goal is to basically encourage patients patients to work on nutrition and lifestyle as a way to either defer or delay dialysis. One of the things I think I'm having a lot of challenge with and not necessarily getting the providers on board to look at the clinical data about how nutrition does play an important role in patients' health. And I know that because we are actually lucky enough to have a nutritionist in the nephrology department that patients can meet with. But more so, like, is there any clinical data in like layman's terms that I can present to patients to really encourage them to work on their lifestyle? I think, unfortunately, as much as we, as providers in healthcare, we know nutrition, we know how much it helps, but sometimes, it's a little tough for our patients to get on board with it because it does require so much change. And then if you had any local resources or things of that nature to help our patients that are financially insecure, that's also helpful.
Financially insecure, I could help with less than some recent toolkits. And one of them is from the American College of Lifestyle Medicine, which I think just 2 or 3 months ago came out with a whole new toolkit for providers about how to talk to both medical professionals and patients about the importance of food as medicine. And it's a step-by-step guide they've been working on for 2 or 3 years. They're very excited about it. The Teaching Kitchen Collaborative has curricula and resources on it. You've probably encountered them. Emily is nodding her head. They've been terrific in trying to advocate nutrition education. A gentleman who works with them and teaches at Harvard School of Health just wrote me yesterday about calling for nutrition education. So that's a big, for culinary, medical culinary education. So that's a big increasing movement. But as far as what translates it and what medical professionals can take seriously, I'd start with the American College of Lifestyle Medicine because they've been very active in this. And did I see that Maine is applying for something in whole person health? And I think it's the Association of Integrative Medicine that's also, it's whole plate health or whole person health that's also trying to do this. But this very explicit toolkit around food as medicine and healthcare providers is the American College of Lifestyle Medicine. And they try to make it very accessible. And they've been partners of ours, and especially the diabetes convening we did, which was gathering together lots of clinicians in diabetes. And they haven't released it yet, but it's quite exciting. So ACLM.
Great, thank you. And Gina McKinney's also asking about, this is a really sad day for a lot of us because this is the last day of SNAP Ed. And we've had them for many years, and nutrition educators that have been sprinkled across the state, and really, and in Maine at least, they have been co-located in places like our food pantries and our hotels housing asylum seekers, and senior places serving seniors and kids, and really being a very strong presence of how to shop and cook and eat healthy on a budget. And of course, that's now gone as of today. So anything, she mentions that there may be some, HRSA's maybe mentioned some backdoor funding for nutrition education, but any ideas how we replace SNAP Ed?
I have to find out what the HRSA workaround has been. I would say there's one other, but they're both through HRSA, and I don't know the actual mechanism, and I'll look into that. But I've had at least one state say with assurance, oh, we've found a way around that. It wasn't the same extent of SNAP Ed that was under USDA, but it was certainly finding, could it have been under mental health? It was something that was still funded by HRSA that they could use education funds. It was stretching the rules because they weren't specifically around nutrition education, but it was around education and health that they were extending. So I'm sorry to be vague, but I will also look that up.
Well, it's helpful to know that there might be some backdoors because it's been extremely valuable. MaineHealth is, we've employed about 6 or 7 of them, and they've been extremely valuable in our, across our service area. And I think we're coming across 1 o'clock. So, oh my gosh, it went so fast. It's just, I could listen to you for another few hours. It's been so wonderful and such an honor to have you join us. Also, I just want to mention we do, Emily, we have the M&Ms on the call here, Emily Kane and Emily Walters, we call them M&Ms here, but so we're very, and Carrie Gordon, who's usually is a medical director for Food is Medicine, it could not make it. She had a long-standing conflict, but I know she was very excited to listen to you, at least a recording. But they do a lot, including a curriculum that they provide for the food service workers for schools in Maine, to how to cook for school kids, K through 12. So anyway, so it's a lot of food is medicine type of work that they do under healthy eating and active living. So we're very excited to have that team who really are really on the forefront, I think, particularly for health systems. So thank you, M&M and Carrie, for listening later, and the other members of their team, Gina and others. So, but particularly want to thank you, Corby, for taking the time. I know you're extremely busy and very high demand. And Alan has been also putting links into the chat, your book, the article from the New York Times yesterday, and other resources, and the Aspen Institute. If you haven't listened to his session from last summer, or this summer, it was very well, very, very worth the listen. So thank you so much, Corby, and I hope to see you in DC with John sometime in the next few weeks at some of the meetings that we'll be hopefully both at. So
do I.
Thank
The
you.
honor has been mine.
Thank you so much.
You
Thank
take
you.
care.
Thank you.
Bye-bye.
Bye.
Thanks.